Hi, everyone. I'm Mimi Sato-Re. I'm a family practice doctor out in the Folsom El Dorado Hills area of California for the last almost 25 years. And I've been using LDN for about, I'd say 12, or sorry, I've been a functional medicine doctor for about 12 to 14 years. And I've been using LDN, I would say like 7 to 10 years, somewhere like that. And, first you start slowly and are timid, but now I think it should be in the water. Shoot. It's great. I really have appreciated learning a lot about it, and I appreciate Linda Elzagood putting on all of the LDN research conferences, and thank you, Masood Rashidi, for allowing me to speak today. So I've been using LDN for a while, and I did the American Academy of Anti-Aging and Functional Medicine fellowship and advanced fellowship, and I've also done their board certification. So I have a traditional practice, family practice, and a functional medicine practice. And so I'm speaking today kind of a hybrid of community at large and some providers who might be listening as well, and patients. So hopefully I won't be too far on one side or the other or speak too scientifically, but there's a lot of great research on LDN, and it's important because you need to know that there is evidence-based medicine behind this, and it's actually a very awesome tool. I don't claim to be an expert on LDN. I just love to practice functional medicine, and I like it being in my tool bag. I know that there's more and more providers that are interested in LDN, and we didn't get it in medical school at all. So, you got to get it somewhere, and here it is. So, okay, so this is LDN and how I use it in my traditional and functional medicine practices. Masood went through a lot of this, so I'll just kind of go over this a little bit faster so we can get to the cases eventually. But naloxone was the parent compound that was discovered in 1966. Naltrexone is closely related to naloxone. It's more orally bioavailable. And then naltrexone is a synthetic opioid that's similar to oxymorphone. It was, introduced way back when in the 1970 for overdose, treatment of opioid overdose in 1984, the treatment of opioid addiction in the 1990s for the treatment of adult alcohol use disorder. And naltrexone in its current dosing is 50 to 150 milligrams per day, but that's not what we're talking about. We're talking more about low dose naltrexone. But naltrexone as a compound is highly lipophilic. That means it is actually spread throughout the body by passive diffusion, and so it doesn't need a receptor. It doesn't need something to carry it. It really is widely distributed, and including it goes into the brain easily. It crosses the blood-brain barrier, but it succumbs to what we call first-pass metabolism. So when you take it orally, the liver, when it metabolizes, it lowers the absolute bioavailability. The active metabolite is called 6-beta naltrexol, and it's converted in the liver, and the half-life can be as long as about 13 hours. Greater than 95% of naltrexone is cleared by the kidneys. So, we want to make sure people have healthy kidneys to use it. But really it's safe, and it's available orally, injectable, intranasal, and topically. So naltrexone activates the opioid receptors, especially the mu, kappa, and to a lesser extent the delta receptors, and it's by reversible competitive antagonism, which is what Dr. Mathewson had talked about. The mu receptor of the opioid receptor, when it is engaged, it blocks euphoria, so people don't get euphoric or high from using naltrexone. The kappa receptor, when it is blocked or engaged, it causes a negative effect of dysphoric stress. The delta receptor, when it is negatively or blocked, it creates a positive anxiolytic effect. So people feel less anxious when it's effective on that receptor. So naltrexone blocks the reward pathways, so you can use it for weight loss because it blocks pleasure-seeking pathways. So like people, when they eat for stress or for joy, they don't get the dopamine surge or experience euphoria when they're taking LDN or naltrexone. And naltrexone also improves compulsive behaviors like gambling, purging, binge eating, self-injury, and urges. And they have done studies with autistic kids and LDN, and that's how they found out that, hey, these kids actually are less apt to commit self-injury and more controllable. So there are other opioids and naltrexone, they completely competitively bind the opioid receptor, but LDN transiently, that's the big difference, as Dr. Mathewson was saying, transiently competitively blocks the production of, it transiently competitively blocks the opioid receptor, which produces an endogenous opioid, which is our endorphins, and enkephalins, which is something called metenkephalin, which is also known as the opioid growth factor. It's currently thought that a greater than 6 milligram dosing may not preserve the endogenous endorphin rebound effect or the anti-inflammatory effects. So there is, like Dr. Rashidi was saying, there is a sweet spot. It's like Goldilocks, not too much, not too little. You want to be right in the sweet spot, and everybody's sweet spot is different. And you just have to try it and see what it will be for each person. During the state of transient competitive blockade of the opioid receptors, the levels of endorphins and enkephalins remain high. And our endorphins and enkephalins are the things that make us feel good. It relieves pain. It makes your whole psyche feel better. And the higher levels of endogenous endorphins and enkephalins may promote healing in the body, inhibit cell growth, and reduce inflammation overall. So the other speakers have said, yeah, the traditional dose of LDN is 1.5 to 4.5. Studies that have been used with LDN have shown that they have been great adjunctive or standalone treatments for Crohn's disease, multiple sclerosis, fibromyalgia, chronic fatigue syndrome, major depressive disorder, Ehlers-Danlos, cancers, complex regional pain syndrome, Charcot-Marie tooth disease, Haley disease, which is like what's called a pemphigoid kind of bubbly disease, lichen planopilaris, which is a disease where you lose your hair, and guttate psoriasis. So I just, for fun, I Googled or PubMed, I looked up LDN, I put in LDN, and 388 articles popped up, and I was like, wow, that's awesome. So there's more and more people looking at LDN, and I'll talk about some of the research at the end of my talk tonight. So most of the studies, or more of the studies, have been done with anywhere from 0.75 to 6.0 milligrams orally. And the pain studies have used doses as high as 6 to 9 milligrams twice a day, but usually they're about 6 to 7 milligrams twice a day. For other diseases or certain diseases, I've gone as high as 13 milligrams a day, once a day, but it's different for everyone, and you'll see that when I go through my cases. So LDN also can have a lot of applications on the skin because you have mu and delta receptors, opioid receptors, if you can believe it. The mu receptors are in the epidermis, and the delta receptors are in the cell junctions in the skin, which, we didn't think that opioid receptors in medical school, or at least when I went to medical school like 20, 30 years ago, it wasn't a huge part of our education, but we've been finding so many more things out about the opioid receptor itself. So there's intermittent blockade of the receptors. It increases ligand and receptor expression, potentiating the effect of reducing cell proliferation, cell migration, and cell adhesion. So LDN may be helpful for therapies involving pruritus, which is itching, inflammation, and acantholytic diseases, which again are like blistering kind of diseases that may, especially if those diseases are refractory to other therapies. So LDN, besides working on the opioid receptor, it also works on other receptors called Toll-like receptors. And we think specifically there's been research that it activates receptors, one receptor called Toll-like receptor 4 or TLR4. And that when it activates it, it mediates the host's immune inflammatory response. And so TLR4, Toll-like receptor 4, resides on the surface of many immune or inflammatory cells like macrophages. And macrophages are some of the first cells that when your body sees like a pathogen or infection or something, bacteria, virus, whatever, it'll go and try and eat it and kill it. So TLR4 is activated when it sees something called lipopolysaccharide, which is an endotoxin, or when the receptor is activated, or when the cell or the body detects stress of the host or damage in the area. And this diagram, I don't know if you can see my pointer, but I'll think you can, so I'll just do it. And so this is a macrophage, and here's the Toll-like receptor 4 here, and LPS, or the lipopolysaccharide endotoxin, would bind it, and then that would start a cascade of events where nuclear factor kappa beta in the nucleus of the cell would then translocate out and start making the cell produce inflammatory cytokines. And inflammatory cytokines are basically messengers that you're calling for more inflammation, calling for more white blood cells, calling for more cells to attack whatever it is that the body thinks is a pathogen or even non-pathogen, but deems a threat. So sometimes inflammation is good, but sometimes inflammation is bad. So inflammation is good when our bodies are trying to kill something, right? Because we think it's not good for us. But sometimes in this world where we, as Dr. Rashidi said, eat too much sugar and we walk not on the ground with our feet barefoot in the grass, we have more inflammation than we should. So sometimes the inflammatory response, which is adaptive to kill invading pathogens or other threats, by inducing inflammation in infection and non-infectious conditions, becomes maladaptive and then persists, resulting in chronic or excessive inflammation. And chronic or excessive inflammation is not our friend. The next slide just says the LDN may bind the Toll-like receptor 4, preventing the release of those inflammatory cytokines. And thereby it may actually limit the host's detrimental response designed to contain the pathogen. In the brain, microglia are macrophages in the brain, and they predominantly express the Toll-like receptor 4, and LDN can block that or reduce the neuroinflammation that occurs. So when LDN is treated on macrophages, or they give it to macrophages, they actually have found that those cells can perform enhanced phagocytosis, which means they can eat whatever pathogen even better than normal. And that increased killing by the macrophages may allow LDN to treat infections. So there's a study that I came across currently that's going on in Africa where they're going to use it to try to see if they can treat AIDS. So, and LDN also increased the T regulatory cells production of nitrous oxide, hydrogen peroxide, cytokine IL-12, and TNF alpha. And those are cytokines which may contribute to the enhanced macrophage phagocytosis, which can be a good thing for us. So LDN, another study that I came across, found that LDN may not only reduce inflammation, but it also may improve insulin resistance. So it may be a good thing for us to use with diabetics. And LDN may reorient macrophages towards an anti-inflammatory effect. And I'm not even going to go into this part because it's just too much science, but there is science behind why it would prevent the inflammatory response that the cell would do, or the pro-inflammatory response. So there are other studies that are finding that LDN reduces many inflammatory cytokines. There was a study done by these guys are Stanford docs, Parkitney, Luke, and Younger. They are Parkitney and Younger, and they did a small study in 5 women with fibromyalgia. And they found that there's a 15% reduction of symptoms of pain with fibromyalgia and 18% reduction of overall symptoms of fibromyalgia. And they were able to actually measure that the inflammatory cytokines were actually lowered by LDN. And they were able to see that the ones that were particularly lowered in this study were the ones most responsible for nociception, allodynia, and hyperalgesia. So those are the ones basically involved with pain. So lowering of the inflammatory cytokines can affect many types of cells and act on many receptors. We probably don't even know everything that LDN can do yet or does do, but we're finding out more and more things. But we think that it lowers inflammation, causes, which would be the cause of swelling, pain, cancer, pruritus or itching, fatigue, autoimmune processes, and mood dysregulation, just to name a few things that we think that it could affect. So there's some of the science, and again, we probably don't even know everything that LDN does, and it does also balance the what's called a Th1 to Th2 system of your innate immune system. Basically, the Th1 system of your immune process or immune system, it lobs artillery bombs if there's an invader or pathogen coming in. So it lobs artillery bombs, and anything that's left, the Th2 system goes in and makes antibodies to clean up and try to kill. Well, when you have chronic inflammation or maladaptive inflammation, your Th2 system is too high, and it's like thinking, I got to make more antibodies, which pushes people towards autoimmune disease. And what LDN does is actually decrease that Th2 response and telling the body, hey, you don't need to be making all those antibodies. There's nothing here, nothing to see, nothing to kill. And so it balances out your immune system, which is a great thing. So does it have side effects or interactions? Really, it's pretty clean. It does cause insomnia for some people, and we think that's because it about 3 to 4 hours after you take LDN, which we suggest you usually take at night traditionally, you get this release of endorphins that your body's making. And so if you're asleep and then you get this release of endorphins and you're like, okay, I'm awake now, and what do I do? So it can cause insomnia for people. And if that happens, we usually tell them to take it earlier in the day, either the afternoon or morning, and usually that improves that side effect. Headache is another side effect sometimes that we hear. And one of the speakers for the A4M thinks that it usually is used, it's usually because the person's not used to the release of the endorphins, so they get a headache from that release of the endorphins. So again, if the person's having a headache, you can back down on the dose a little, or stay at the same dose until that subsides, and then move up slowly if you even need to. Another thing that I have heard, not very often, but sometimes you can have GI upset because it is a mild prokinetic agent, which means it does make your gut move faster. So, but usually the effect goes away after a couple weeks. But if you are, raising the dose, it may stay until you finally get to your final dose. But if they can hang in there, it usually gets better. Also, people have vivid dreams, and they will say, oh my God, it is like watching HD. You're just dreaming in this really, really vivid environment. And if that happens and they don't like it, usually it gets better after a while, or maybe they can go down on their dose because it may be too high for them. And so the only the interaction really that I feel is like significant is the caution for use with opioids, because you just need to make sure that you don't give them LDN while they're taking their opioids, because they'll be kind of mad because their opioids will not work. So how do I use LDN? So I think about using LDN whenever inflammation is a possibility. And Pamela Smith, who's a big speaker for the A4M, feels that diseases of aging, or any disease occurring after the age of 40 years, is inflammation, inflammation, inflammation. So, anything that is high blood pressure, high cholesterol, diabetes, all the common conditions that occur later in life, those are all inflammatory, and cancer also is inflammatory. So, LDN can be applicable to so many diseases. So first I'm going to talk about fibromyalgia, and Stanford has used LDN in their fibromyalgia clinic for years. This is a 57-year-old female who was diagnosed with triple marker negative breast cancer prior to 2009. And she was living down in Southern California in a moldy cottage by the ocean. And after she went through her surgeries and started treatment for her breast cancer, she developed fibromyalgia around 2009. And she moved back up to Northern California to be near her family who's up here. And she was having severe just SI joint pain, having to get injections, just having all kinds of body aches and all the symptoms of fibromyalgia. She went to the Stanford LDN clinic and they gave her LDN and she got up to the 4.5 and she's continued on it. And she has said to me, that medication is a game changer. It changed my life. She continues on it because she also remains fibromyalgia free for symptoms, and she's also remained breast cancer free for the last 13 years. So that's a winning story. My next patient is a pain management example. He's a 65-year-old guy who had severe low back pain and shoulder pain, which was due to a complicated rotator cuff tear, but he had severe low back pain. He's an avid golfer, and every time he would go out golfing, he would just be suffering when after he golfed. Nothing was helping his low back pain. Multiple physical therapy sessions, oral analgesics, but he didn't really want to be on, chronic opioids or chronic pain medications. So I said, please, let's try LDN. And actually this dose is wrong. I just checked it today and it's actually not the right dose that he's on. But he actually is taking, got up to 4.0 milligrams twice a day. And his low back pain is amazing. And he sings the praises of LDN to anybody who will listen, and is able to golf again and not complaining of his low back pain. He also had to have rotator cuff surgery. And I was thinking, well, I hope things go okay, because, he may have a lot of inflammation, but because he was on his LDN, I feel his recovery was really excellent. I spoke to his orthopedist after his surgery, who said it was a really complicated repair, one of the worst he's seen, but the patient actually sailed through recovery, physical therapy, and is back golfing and has not looked back and is not going to stop his LDN. So another great story. So I use it also in autoimmune disease. And here's a 59-year-old female who came to me as a new patient. And she had a lot of stress over the last year because her daughter had been diagnosed with mast cell activation syndrome and was very sick and was on the East Coast. She was in menopause, and she had started taking bioidentical hormone replacement. Her dog was dying. She had 2 other close family members that she was having to take care of that were very sick. She wasn't sleeping. They started needing to treat her for depression. Then she developed vulvodynia, or pain in the vagina and vulvar area. And she was having severe dyspareunia, which is severe pain with intercourse. And she couldn't even wear yoga pants comfortably. She had to use lidocaine gel and white knuckles just to have intercourse with her husband. And the poor thing, eventually she was, or I think before she came to me, she was told that she probably had lichen sclerosis, and she had tried the topical steroids that they used to treat it, but it was not helping. So I said, let's give LDN a try. And so she's like, okay, we started at 1 milligram and went up by 1 milligram every few weeks. And she finally got to 4 milligrams. And she's like, this is good. This is really good. And so she was feeling very good. And it kind of was interesting to me, because she kept trying to say, I'm going to go off it. I'm going to go off. And I think I'm better now. I think I'm better now. Well, the symptoms started to come back, usually after about 6 weeks. So that she went off, tried to go off it 2 times. So finally the 3rd time she's like, okay, I'm going to stay on it. And she's continued to use it, and she's doing great. She can have intercourse comfortably, and all she has to use is lubricant. And she can, wear yoga pants. She doesn't have pain all the time. And so another life-changing LDN moment. So this is another female with autoimmune disease. She's a 42-year-old patient who was diagnosed with a rare disease called autoimmune progesterone dermatitis, or urticaria. She basically is allergic to her own progesterone. So her symptoms of severe urticaria, and she would have it pretty much all over her body, except for her face. And she would have it nearly every day. And it was worse during certain points in her cycle, worse when the weather was warm. She had to undergo IVF to conceive, and she was able to have one child, which was great. She was having to use antihistamines. The urticaria didn't happen until after, about a year after she had her child. And she was having to take antihistamines chronically. It wasn't really even working. And she would just be like, I have to go soak in a cold tub because she just didn't have any effective treatment. And there's like one guy that her allergist told her at Duke who's studying this, and it's just very, very, very rare. So I begged her to start LDN, and we started at the traditional. We went to the 1.5, we went to 3, we went to 4.5. She was still having probably 50-50 symptoms. And then I said, let's go a little bit higher, because at some of the LDN conferences, or one that I went to, I spoke to some of the practitioners, and they said, yeah, sometimes you have to go higher, especially for skin things, sometimes, or gynecological vaginal things, sometimes even as high as 11 or 13 milligrams. And so I said, let's go a little bit higher. So we went to 6, and things got probably like 80 to 85%. She was better. And then finally, she's like, okay, let's go to 9. And now she's about 90 to 95% better, and she barely has symptoms. And she's a celebrity or in the public eye, so she can't really afford to have, this happen to her. And she's doing quite well right now. So she's very happy, and she's continuing her LDN as well. Okay, here's another patient, a 58-year-old lady with diabetes type 2 and Hashimoto's thyroiditis. She started developing severe hand, finger, joint pain, and we figured out that it was erosive osteoarthritis. So I said, let's please start LDN. It'll be a 2-fer, and now I even know it's a 3-fer for her, that for the Hashimoto's thyroiditis. So we started at 0.5, and we slowly titrated up by 0.5, and she finally got to 2 milligrams, and she's like, I don't have any pain in my hands anymore. So I think that's my dose. So that's where she is. And her diabetes is actually, she was able to come off metformin. And so she's not needing metformin anymore. She's mostly diet controlled. I did send her to the rheumatologist, and he decided to put her also on hydroxychloroquine. And he said that he was actually happy that I had already started LDN for her, which I was shocked, because what rheumatologist, it's hard to find a rheumatologist that would, be excited about LDN. So there is one in the area, which I can share later. So this is a child with autism. He's a 3-year-old male child who is moderately to severely autistic. No eye contact with people, siblings, not playing with them, not interacting. He would have repetitive behaviors. He was gluten sensitive, and he wasn't in preschool, and he wasn't talking either. So the parents brought him in, and I said, let's try LDN. I just went to a conference. I think it would be a good thing. Let's try it. So we started with 0.1 milligram topically, because, kids don't like to take medication, especially sometimes autistic kids. And so they just started rubbing it in for him at night as a ritual when they went to sleep, and read to him and tried to calm him down. And we went up, every 1 to 2 weeks. And finally, when we got to 0.3 milligrams, the parents called and said, he's starting to make eye contact with us. He's making eye contact with his siblings and playing with them, interacting with them, which was like amazing. And unfortunately, they moved to Tennessee, and I lost follow-up. So I don't know if they're still using it, but it was quite miraculous and significant to me. So I also will think about it with kids with autism. So this is a patient who I used LDN with, who had a COVID vaccine injury. 52-year-old, really healthy guy, running 5 to 7 miles a week, 4 to 6 times per week. It's like 5 to 7 miles a day, 4 to 6 times per week. His symptoms occurred within 48 hours of his second Pfizer COVID vaccine. severe fatigue, myalgias, muscle pain, brain fog, muscle spasms. He had this weird buzzing vibratory thing going on within his body that he said he just felt all the time. He couldn't sleep. He was having weakness, all different things. He was like having difficulty swallowing. It was just weird. And he could barely walk to the mailbox after being able to run, 5 to 7 miles easily. So we've done a lot of things with him. I've been working with him for a few months. And finally, we started LDN a few months ago, and he's had the biggest change probably in the last 2 to 4 months, and he's back running 2 to 4 miles, 3 to 4 times a week. He's working full time. His brain fog is gone. He's just doing much better. So it is another way to use LDN. And here's another case that I forgot about, and I just added today. It's a 45-year-old female who was complaining of lung discomfort, which started she let it go for 2 months after she had had an upper EGD or upper scope and colonoscopy. And she would describe the feeling as itchy heaviness in her lungs, and it's painful to take a deep breath. And she had an anterior chest wall pain as well as left upper abdominal pain. She had constipation. She was having joint hypermobility already, which we were wondering, does she actually have Ehlers-Danlos, which is a hereditary hypermobility collagen disease? She had also had a history of bilateral patellar kneecap dislocations in college, and she actually had to stop running eventually competitively because of that. So she had a GI workup. It was negative. We checked her chest, CTs, everything. Couldn't really see what was causing her pain. So I figured it may be myofascial partly, and nothing was even touching it. And she was like, I don't want to take opioids, and it wasn't even helping anyway. So, and the anti-inflammatories weren't really effective. And I said, let's try LDN, please. And I started her on the traditional dosing. She got up to the 4.5, and she's like, the pain is gone. It's amazing. She's like, I'm never coming off this stuff. And she's still taking it to this day, and she's doing great. So that's her. Then I think this is my last case. So is a lady who's 67-year-old lady who was diagnosed with rheumatoid arthritis years ago. She was starting to have symptoms in her hands and wrists of pain, joint pain. We started LDN when I met her, I believe it was about 4 or 5 years ago. And was started on LDN, and we moved her up. She's on the 4.5. And it's been about 5 years since I met her, and 5 years before that, she was diagnosed with RA, and she still has no signs or symptoms of rheumatoid arthritis. So what's interesting about this lady is that she was exposed to COVID twice, because her husband caught COVID twice, and she has never gotten COVID. And actually, this is a great segue into some of the research that I found as I was preparing for this talk. This is something from the Frontline COVID-19 Critical Care Alliance, which is a small group of really astute physicians who are looking at evidence-based studies from around the world, not just in the United States. And they have actually recommended LDN as part of their first-line therapy now for the management of long-haul COVID syndrome, which we know we don't have any treatment for long-haul COVID syndrome. So I thought that was quite exciting. And I found an article by Chuby and et al., and it's called Naltrexone, a potential therapeutic candidate for COVID-19. And we don't really have good therapy for COVID-19, but we know that people who have certain diseases, inflammatory conditions, are at higher risk to do poorly. So diabetes, older age, cardiac disease, high blood pressure, high cholesterol. And these conditions are all consistent with elevated cytokines or inflammation. And so we know that COVID provokes a cytokine storm, and that's when people need to get hospitalized and they go into multi-organ failure and death, when the cytokine storm just takes off in their body. And in this article, here is like the summary of the article. If you want to read it, I can get you my slides somehow through the LDN Research Trust. But basically, it's saying that LDN probably prevents or helps with COVID in a couple of ways. First, you have the ACE2 receptor that the COVID spike protein usually binds to. And then when it binds to that receptor, it's taken into the cell, and then the COVID virus hijacks all of your machinery inside your cells to replicate itself and increase the viral load. Well, what LDN does, it's so smart. It sits in between the ACE receptor and the COVID-19 spike protein, and it blocks about 4 hydrogen bonds that are there, and that causes the ACE2 receptor not to bind and take in the virus into your cell. So it blocks it from actually getting taken up into your cell. Another way LDN helps would be to block these kinases or enzymes called the ERK1 and ERK2 kinases. And what those do are they're involved in the replication of viruses or what the virus takes over into your body. So it blocks that process. And so the virus can't infect you and it can't replicate, and therefore it can't increase its viral load. So LDN may be an exciting new therapy for COVID. So Linda, I hope someone's like gonna research LDN for COVID, because it might be a really, really amazing thing. I mean, because I've had other patients as well who take LDN and who have never gotten COVID. So maybe we're just more careful, or they're more careful, but it might be a really awesome thing to do. You have to pre-treat with the LDN. It's not, I don't know that the study looked at treating it at the time. You have to pre-treat before you get exposed to COVID. So we feel that LDN blocks something called the NOx enzyme, which is nitric oxide synthase, which is the enzyme that activates interleukin-6, which is the main inflammatory cytokine of COVID-19. So that LDN, there's another way that it actually may block or help treat COVID-19, and it inhibits those ERK1 and 2 kinases, which by activating or blocking them reduces the replication and viral load. And then there's the disruption of the binding of the spike protein, which doesn't allow the infectivity of COVID. And there was another article that I came across that LDN may actually affect both the immune and thrombotic dysfunction in COVID-19. So it might prevent the clotting issue as well. So LDN has many, many beneficial applications. And again, we don't even know how many things it does in the body. It just seems to, we find that it does more and more good things in the body, and it's such a low dose. It's a low cost, low side effects, no significant interactions, except you have to be careful with the opioids. And it's very orally bioavailable, but you can also use it in many other ways. So I hope that all of you will consider trying it, patients and providers alike. I also believe that there's so much more yet to be found with LDN, and I just appreciate you giving me the opportunity to talk to you tonight.